everyone to another edition of our NSWOCC and Walk Institute Continuing Education Webinar Series. It's actually our last one of 2024, so we're really excited to have you on here. I'm trying to give everybody a couple seconds to start joining the webinar, but as we do that, you all know it's one of my favorite ways of breaking the ice here. If you don't mind opening up that chat button in your Zoom toolbar, I see people are already putting some comments in there. Please let us know where you're tuning in from, whether it's somewhere across Canada. I know we might have some people from the States joining us or internationally, especially with our noon start time today, noon Eastern start time. So amazing. We got people from Regina, Halifax, Moncton, Lethbridge, Toronto, Nova Scotia, Ottawa. Fantastic. Well, my name's Troy. I'm our Director of Operations for Nurses Specialized in Wound, Ostomy, and Continence Canada. I'm based in Ottawa here. And we're so excited to have another webinar presented today with in partnership with First Quality. So we really want to thank First Quality for the support today and bringing us this fantastic education. As you can see on the slides here, today's topic is going to be on strategies for effective prevention of incontinence-associated dermatitis through incontinence management. What are the clinician and physician roles? And before I introduce our guest speakers today, I'll just do a couple little housekeeping items. First, we're going to be recording today's session. So if you need to head out early or if your colleagues want to watch this later, you will be able to access that on our NSWOCC website. We are going to be doing a Q&A portion at the end of the webinar too. So if you don't mind clicking on the Q&A button in your Zoom toolbar, if you have any questions, that'll make sure we can get to those pretty succinctly towards the end as well. And then finally, everyone will be receiving a certificate of attendance today. So do stay tuned for an email within the next 2 days from our nswok@gmail.com email address. So without further ado, I'm really excited to introduce our two speakers today. First, we have Michelle Mongillo today, who is the Senior Clinical Director for First Quality Products. She has overseen the development and implementation of the clinical programs and services at First Quality for the past 19 years. And at First Quality, Michelle has developed innovative educational programs, including CareSource, which focuses on person-centered care for the incontinent individual. She has collaborative clinical relationships with the University of North Carolina Chapel Hill School of Nursing and is an adjunct faculty member and a guest lecturer at the Pennsylvania College of Technology Nursing School. She has over 30 years of nursing experience in a variety of settings, including acute care, head and spinal cord injury rehab, home care, and post-acute care. And so this nursing experience also includes direct patient care, unit management, administrative, and corporate senior leadership. She has held a variety of roles in skilled nursing, including nurse manager, director of nursing, regional nurse, and vice president of nursing services. And she's is a co-author of Prevailing with Incontinence, a Nurse's Guide. So we are so happy to have Michelle here. We also have Dr. Neal Buddensiek, who is a practicing board-certified internal medicine physician with over 18 years of experience. He serves as president of Post-Acute Medical Direction, where he works as an attending physician, consulting physician, and medical director at skilled nursing facilities, assisted living facilities, and hospice care. Dr. Buddensiek is also a medical consultant for one of the largest Catholic long-term care and senior living companies in the United States, and serves as a medical expert witness in medical legal matters involving the skin and soft tissues. Dr. Buddensiek received his medical training at Creighton University School of Medicine in Omaha, Nebraska, and completed his residency at Abbott Northwestern's Hospital Internal Medicine Residency Program in Minneapolis, Minnesota. He is board certified in internal medicine through the National Board of Physicians and Surgeons, a certified medical director through Post-Acute and Long-Term Care Medical Association, a certified hospice director through the Hospice Medical Directors Certification Board, and a certified wound care specialist through the National Alliance of Wound Care and Ostomy. And Dr. Buddensiek is very passionate about caring for the medically complex geriatric population and building high-functioning interdisciplinary care teams focused on the continuous quality improvements in clinical excellence. And he lives in Minnesota with his wife, 3 children, and 2 cats. So without further ado, I'm going to pass over our mic and the slides to Michelle. Thank you so much.
Thank you so much, Troy, for that introduction. Dr. Buddensiek and I are excited to be here today and share some information with you. So first, I'm going to go over the learning objectives for today. Keep in mind that Dr. Buddensiek and I, when we're speaking today, are probably focusing more towards the post-acute environment. However, we both feel that this information really is applicable to almost any healthcare setting. So first, we want to determine the pathology and mechanism of IAD, including the role of moisture, irritants, and friction in skin breakdown. Describe the clinical presentation of IAD and the impact of comorbidities, including diabetes, obesity, vascular disease, and malnutrition. Describe the relationship between IAD and pressure injury. Familiarize with current prevention management guidelines protocols for treating IAD, including the use of topical treatments, dressings, and other therapeutic interventions. Define key components of an effective incontinence management program, including prevention strategies to reduce the incidence of IAD. And then finally, discuss the appropriate selection and use of absorbent products in relation to skin health. So I'm going to go ahead and turn it over to Dr. Buddensiek to kick us off.
All right. Thank you, Michelle. And thank you, Troy, for that nice introduction, and Michelle for sharing those objectives. It's a great honor and privilege to be with you all today. And we're going to just jump right into this. We have a lot to cover. And I think this will be as up to date as one can get with regard to incontinence-associated dermatitis. I've been reviewing the literature, and we're into at least late 2023 with regard to the data here, where it exists. So we're going to start out a 30,000-foot review of the incidence and prevalence of fecal and urinary incontinence, and then we'll get down onto the runway or the dance floor where all of our direct care providers service our patients and residents, as well as our leaders. So overall, there are about 420 million people worldwide who have been affected or are affected with urinary incontinence. We have to keep in mind that this is an underreported condition. There still is a lot of stigma around this, and people don't like to report what they're dealing with each and every day. Oftentimes it isn't reported until it's so bad that they have to seek professional health care. There's nearly about 9% of the world's population over the age of 20 that suffers from urinary incontinence. And as far as the identity and gender, about over 12% of women, that's over 300 million people worldwide, are affected by urinary incontinence. And as far as men, about 5% or 120 million worldwide are affected by urinary incontinence. Next slide. With respect to fecal incontinence, another very distressing condition. Quite often, even people that have what might be called irritable bowel syndrome may have a prevalence of diarrhea or fecal incontinence. You can see throughout the world variation in prevalence, again, underreported, but approximately 1 in 12 persons worldwide have fecal incontinence. It's more common in the older population, greater than 60 years of age, and more predominant in women, again, perhaps because women are willing to report more often than men, knowing myself being a man. And the bias in studies is variable, and exclusion of studies with high risk of bias does not believe to affect this prevalence. So in our North American area, you can see anywhere from a prevalence of fecal incontinence of around 9 to 10%. Next slide. So now we're going to zoom onto the runway or the dance floor and talk about specifically incontinence-associated dermatitis. As many of you know, the umbrella term, moisture-associated skin damage, is one of the 4 characteristics clinically. So we have incontinence-associated dermatitis, which is specifically a irritant contact dermatitis caused by chronic or prolonged overexposure to the skin by body fluids, specifically of urine and or feces or in a fecal effluent. The other 3 clinical manifestations of moisture-associated skin damage are peristomal dermatitis, intertriginous dermatitis, and peri-wound maceration or moisture-associated dermatitis. We won't talk about those today, but we're going to get more into detail now about incontinence-associated dermatitis. Interestingly enough, there are variations in what the definition is or what people believe across the world believe incontinence-associated dermatitis is. But most often it's felt to be inflammation or erosion of skin that's caused by prolonged exposure to urine and or stool. And it's very imperative that we identify the correct cause of and differentiate incontinence-associated dermatitis from other skin conditions, because once you've diagnosed it, you can then begin to treat it. And even before that, hopefully we can prevent it. Next slide. So let's provide a little background now on incontinence-associated dermatitis. As I mentioned, it's a common, under-recognized, and can be painful, rather painful skin condition. The prevalence and incidence in the medical literature is quite broad-ranging, mostly because of the difference in the setting where the studies were done, as well as the difference in the population that the studies were done on. Also within that population, you have variation in how many of those people have incontinence chronically or intermittently as compared to no incontinence. Obviously, incontinence-associated dermatitis is not going to be found in people typically that are not incontinent, only those that have some form of incontinence. But the prevalence ranges from anywhere between 5 to 7% typically in the long-term care population of people living in nursing homes. But across the community overall in home and community-based services, it can be anywhere from 3 to 22%. When you get into acute care environments, it can get upwards of 40 or even 50% of people that develop or are living with incontinence-associated dermatitis. What we also know is that people that have urinary incontinence only, as compared to those that have fecal incontinence or dual incontinence, typically those with urinary incontinence have lower prevalence of incontinence-associated dermatitis. So when you start getting dual incontinence, which is the both urinary and fecal, or the fecal incontinence, that's when the prevalence typically rises. There are studies out there that suggest about 12% prevalence for people with just urinary incontinence, as compared to perhaps 26% in those that are dual or fecally incontinent. We know that there is a considerable amount of discomfort that can be a symptom such as pain, burning, itching in those affected areas. And those infected areas are more than just the perianal or perineum area. We'll have a graphic here in just a second that also shows other areas or anatomical areas of our human body, including the inner thighs, the buttocks, the gluteal cleft, or even the lower abdomen if you have a bit of an extra pannus around that area. What we also know is that quality of life can be affected in loss of independence, depression, sleep disruption, social isolation, and this can be a very difficult condition to treat and also can be time-consuming and expensive. So here you can see the areas that are commonly affected by incontinence-associated dermatitis. I point out specifically the perineum and the genital area of the scrotum and the labia. Then, as we mentioned, it can be the inner thighs, the perianal area, the lower abdomen, as well as the buttocks bilaterally, the intergluteal cleft, or the posterior thighs. Next slide. So now I'm just going to get a little bit more geeky, so to speak, and I'm sure many of you will love this. But this is a cartoon, shall we say, of the epithelium, the epidermis. And we know the epidermis has 5 layers. The top layer is the stratum corneum. That's the outermost layer of the skin. It's our first line of defense. And it is, one can think of it as a well-guarded fortress. In between those bricks, which are those corneocytes or the stratum corneum, we have the interlinking lipid area. Those lipids could be of fatty acids, they can be cholesterol, and most commonly, about 50% of the lipids are the carbamase that is linking those. So we have the bricks and mortar, so to speak, that helps prevent any pathogens, any environmental toxins, any liquid or moisture from going through and penetrating and breaking that barrier of the epithelium. What we also know is that even though it's thin, because the epithelium is typically about 10 to 15 or 20 cells thick, much less in babies, and that's why for the first year of life, especially between 9 and 12 months, is the time when most babies, if they're going to get incontinence-associated dermatitis, typically get that. But we have typically a very thin but mighty epithelium. We have rich lipid matrix. And when you have then that chronic recurrent urine or liquid stool that begins to physically irritate, to chemically irritate, that's when you get the triggered inflammation. You get the edema of the cells, you get the subsequent skin damage, and that's when that loss of the protective function occurs. We want to remember that the stratum corneum has an acid mantle, typically an optimal pH of about 5.6, anywhere from 4 to 6, which is what helps keep the pathologic bacteria low. It also helps the carbamase enzymes work very well and utilize the ability to have all that lipid-rich matrix. And we know that typically the epidermal cells are approximately 70% water. So obviously, optimal hydration, optimal lipid, optimal pH is what drives that great guarded fortress to prevent those fecal enzymes, those urine enzymes such as lipase, urease, protease, in the presence of that ammonia, that alkaline milieu, so to speak, that can cause skin erosions and excoriations. So when we look at the protective barrier function of the bricks and mortar, it can be disrupted by two major forces. One of them is the pH change. As I mentioned, we want optimal acid, about 5.6. But as you get more alkaline for various reasons, whether that be the urine or various soaps that unfortunately are used from time to time that are more alkaline, can affect the pH and change over time. And then also being overly wet, meaning that you have then a higher coefficient of friction and you're more susceptible to mechanical trauma. And that can cause shear and friction when you're cleansing, when you're repositioning, or you're transferring. So a lot can be talked about with that one little cartoon there. Next slide. Want to dive just a little bit into risk factors for incontinence-associated dermatitis, or what are also called prognostic or prediction factors. This is a very interesting area. As I mentioned, people that do not have incontinence typically do not get incontinence-associated dermatitis. But those that do have incontinence, if it's urine as compared to stool or feces alone, it typically gets more prevalent that you'll get incontinence-associated dermatitis when you have that feces, including urine. The indirect or the external types of risk factors that are most heavily discussed in the medical literature that have at least moderate quality studies would include reduction in physical performance and function, reduction in mobility, greater limitation with activities of daily living, impaired cognition, people that have greater friction or shear problems, either due to some kind of musculoskeletal issue or injury. People that have more frequent bowel movements, diarrhea are going to be at more risk for incontinence-associated dermatitis, and as well as those that have not received any preventative incontinence-associated dermatitis interventions. And lastly, those that have been found to have a presence of a perineal pressure injury more often than not will have had incontinence-associated dermatitis or have concurrent incontinence-associated dermatitis. The other lower quality or very low quality studies also do, at least on this list, include increased exposure time, poor circulation, diabetes, smoking, fever, low oxygen levels, critical illness. They are much lower quality studies though, and there's much more confounding there. So right now, as I mentioned, the highest quality studies, which are really moderate quality, include those characteristics of the patient with regard to physical function and mobility, and then that greater risk of shear and friction or increased bowel movements and cognitive impairment. I want to talk just a little bit next about increased age though, and make sure that we are understanding the lack of complete independent risk factor for age. So next slide. We do know that as the skin ages in our older adult population, that skin function can and does deteriorate. We know that higher activity levels of alkaline ceramidase can cause that lipid layer, that lipid-rich layer, to not be as optimal. We also know that the dermis thins out by at least 20%. It can mean having paper-thin skin or more easily developing skin tears. We also know that those dermal epidermal junctions, what we call the rete pegs or the rete ridges, are typically more flat, causing the ability for the epidermis and dermis to separate more easily. And then also the surface pH is less acidic in people as they age. But again, age itself, although associated with the development of incontinence-associated dermatitis, is not an independent risk factor, at least at this point in the medical literature. There is some medical literature out there that says as we age, there is an increased risk of up to 3% per year increase in getting incontinence-associated dermatitis. But again, there are plenty of people that are older adults that are living their best life and also not being plagued by incontinence-associated dermatitis. Next slide. And this is really a nice schematic cartoon again of just what I've talked about, which is the epidermis and the epithelial layer, the thinning out, as you can see, as one ages, less elastin, less fibroblasts and collagen typically. Also, when people are living with wrinkles, it can increase the risk of not only friction, but shear. Next slide. This is just to remind us there are many different categorization tools that can be used. This is the Ghent Global Incontinence-Associated Dermatitis Categorization Tool, but there are multiple tools out there. There is no universal IAD tool to be used at this point. And so just to remind ourselves at least about the Ghent tool, we have category 1A, which is that persistent redness. You can see that there's redness on both buttocks and interesting linear area there. Also into the upper thigh, it looks like, and then the perianal area on that left upper, the 1A. 1B, you can see the persistent redness, and then you have the concurrent clinical signs of an infection, whether that be bacterial or potentially fungal. Category 2A is skin loss, so you begin to see some denuding of the epithelium. And category 2B, which is skin loss with a concurrent infection there. So again, one of many tools, but very good to utilize a tool. Also, want to just spend a moment, because Michelle and I are very passionate about equity and continuing to try to help those that are perhaps not as well helped by our health systems across the world. And certainly we know that in the United States to some degree, that this is a great article, if you haven't looked at it recently, on skin tone considerations. This is the really the first skin tone assessment guide, and it helps us understand, what is the baseline skin tone of those, especially that are of darker pigmented skin. And when that skin tone baseline is observed to be changing, that can be just as important as if you would see erythema, redness, sort of angriness, as we saw on the Ghent tools. So this is a very important thing to know. The typical baseline skin color or tone, you can go into the upper inner arm, and that's where you should measure the baseline skin tone. Next slide. And this you can see here of people with different pigmented skin. On the left, we see typical erythema and pinkness, perhaps a little paleness, and that would be consistent with incontinence-associated dermatitis. On the right of someone with a darker pigmented skin, you very well could miss because there's not a whole lot of erythema. It's more pale, maybe a little violaceous, and certainly the skin pigments you can see, although we don't have the upper inner arm to compare the baseline skin tone, you can see outwards of that darker pigmented skin area that it looks like the skin baseline is lighter. So this is another individual that has incontinence-associated dermatitis and very well could be missed until it's late enough where you're actually getting excoriation, denudement, or even pressure injuries. Next slide. All right, just wanted to spend a couple minutes, especially in my medical director work in nursing homes, assisted livings, and then as a medical expert witness, where I review cases for skin and soft tissue standard of care breaches and whether or not causation can be established. This slide helps remind me that it's not and or, but it could be both and, meaning that when you're looking at someone, especially the sacrum or the buttocks, they may very well have a pressure injury, they may very well have incontinence-associated dermatitis, or they may have a concurrent pressure injury and incontinence-associated dermatitis. But what we know about the medical literature is, especially a lot of the work from Beekman, is that incontinence-associated dermatitis is a predictive factor that is significantly associated with the development of pressure injuries. And people with incontinence-associated dermatitis are up to 5 times more likely to develop pressure injuries compared to those that are continent. And this is looking at a systematic review, meta-analysis of well over 58 studies. And so it is very well established now that there is a significant predictive factor when you have incontinence-associated dermatitis in the development of pressure injuries. Next slide. This is just to remind us from the National Pressure Injury Advisory Panel that pressure injuries are localized damage of the skin and underlying soft tissue, usually over a bony prominence. The injury can present intact skin. That's why it's not always called a pressure injury. This could be a talk in and of itself, but it's due to intense and prolonged pressure and or a combination with shear. And as you can see there, and I know Michelle is going to talk more about this, is it's very important that we appreciate how the microclimate of that area of the skin affects increased risk of pressure injury, such as incontinence-associated dermatitis. Next slide. This is also good to remind ourselves about from the National Pressure Injury Advisory Panel that skin injuries are not all caused by pressure. The mechanism of that increased risk of pressure injuries from incontinence-associated dermatitis is felt to be that wet skin demonstrates a higher coefficient of friction. This then increase in coefficient of friction reduces tissue tolerance to pressure and shear stresses, not only superficial but deeper tissues. The superficial skin changes are the predominant cause by friction forces, and that increase in soft tissue damage ultimately can cause the pressure injuries. But we know that incontinence-associated dermatitis is starting out is an inflammatory condition, but then you can get into increased coefficient of friction, and the skin becomes thus more susceptible to pressure injuries. Next slide. A very nice article and comparing and contrasting incontinence-associated dermatitis versus pressure ulcers. I'll just say that healthcare professionals, when they've been studied, not only looking at a particular picture once and then maybe a month later, they don't have great intra operability consistency, meaning that one individual, one healthcare professional may call something different if they look at it 2 different times at 2 different spaced out periods of time. So it's important that we recognize that we're all human. We do look at things differently from time to time. And then even between different healthcare professionals, there can be differences in whether someone looks at a incontinence-associated dermatitis as a pressure injury or a pressure injury with concurrent incontinence-associated dermatitis. But essentially, the incontinence-associated dermatitis type of skin lesion is more due to, again, fecal and urinary incontinence. It can be diffuse with poorly defined edges. It can be blotchy. It can be pale. You typically have that erythema, again, in people of darker pigmented skin. It can be violaceous. It can be pale. It can just be darker in tone. And then you can see those superficial secondary co-infections with Candida and or bacteria. In contrast to pressure ulcers, again, the cause or the mechanism is exposure to pressure or shear. So if you were to biopsy someone's sacrum skin and you see that there's inflammation, now, not that we're going to do that often, that would be incontinence-associated dermatitis. And if you saw ischemia, which is reduction in vascular perfusion, you would know that that's a pressure injury. Typically, both can cause pain. Again, looking at bony prominences, looking for distinct edges, and looking for where you have a wound base potentially, and that non-viable skins. Typically, necrotic skin will be pressure injuries. Yellow skin, some yellow slough could be either incontinence-associated dermatitis with vesicles or excoriation, or it could be pressure injury. Next slide. What we know is that an ounce of prevention can be worth a pound of cure, and that's no different for incontinence-associated dermatitis. Just want to remind us that there are common skin protectants. We don't want to just cleanse the skin, but we also want to then restore the skin and protect the skin. Interesting thing in the medical literature still is that there is no consensus and no recommendation of one of these over another. Sometimes we do have to remember that constraints of cost do play in a role in this. Also that whether you have a transparent type of skin protectant like petrolatum or petroleum and zinc oxide as compared to a opaque type of zinc oxide may play a role in what you're wanting to be able to see with regard to the skin. If you had the unlimited constraints, you may very well want to use the acrylate pteropolymer. That is a polymer that forms a transparent film. It doesn't need to be removed, can be typically sprayed on once or twice a week at most. And it's much lower maintenance as far as the skin protectant, and yet it's very breathable and can be quite a dramatic, can bring quite a dramatic improvement, especially when people have very severe incontinence-associated dermatitis. Next slide. The last thing that I wanted to just emphasize before I turn it over to Michelle is, as a physician, as a medical director, a lot of times, more than half of the time actually, incontinence-associated dermatitis is managed without the advice of a healthcare professional. It's quite common, unfortunately, that it's managed in the community until it gets really bad. So a lot of times physicians won't be involved in having to diagnose or treat incontinence-associated dermatitis until it's much more severe. We want to always remember that prevention and management education to caregivers is important. Knowledge translation, unfortunately, on what the medical literature says and what we actually do are two different things. We want to really focus on that knowledge translation, not only to our own caregivers and staff, but our own patients, residents, and families. That can be very beneficial in reducing the occurrence of incontinence-associated dermatitis. And then as a physician, when we assess the area of skin abnormality, we want to be able to do the best we can to distinguish between IAD, pressure injury, the co-occurrence, but also thinking outside of that as far as autoimmune conditions, allergic conditions. Those are different in the differential diagnosis, whether it's a psoriasis, a seborrheic dermatitis on the genitals or that area, the perineum area, allergic dermatitis, again, or an autoimmune condition. Sometimes you need to biopsy these areas. Also want to be on the lookout for co-infection. It could be Pseudomonas if you're seeing purulent exudate, green appearance in the wound bed, or a fungal such as Candida albicans if you're seeing white pustulosis surrounding the open lesion, known as satellite lesions or islands in the front of the coast. And then sometimes when things are very severely inflamed, you just need to pull the trigger on using a topical steroid or a topical steroid with a antifungal. So sometimes we'll use a nystatin triamcinolone if you have very angry, very inflamed area with incontinence-associated dermatitis and a secondary fungal infection. So with that, I'm going to, I think, hand it over to Michelle. Carry on. Oh, you're muted.
Sure, you're unmuted there.
Sorry, everyone. I'm going to switch gears a little bit and go into goals of effective incontinence management, and then move into absorbent products a little bit towards the end. So when I think of an effective incontinence management program, first and foremost, of course, is to promote continence. I've seen over and over that sometimes we help our residents or patients become incontinent because of lack of appropriate assessment or intervention or diligence to the issue. So always wanting to promote incontinence with whatever modality is available in our arsenal, from toileting programs to absorbent products, diagnosis, urology appointments, whatever they might be. Also want to prevent complications. Dr. Buddensiek, talked very nicely about IAD. And then we also have to think about infection control. So urinary tract infections, we know that the incontinent individual is at higher risk for developing a UTI. And then there's also complications of fall risk. Patients that are incontinent have a higher risk of falling, and then it can just be kind of a cascade of issues. We also want to restore their ability and avoid further decline. So trying to get that person back to their highest level of functioning, what it was prior to them becoming incontinent, or what it was prior to them coming into a facility, and trying to avoid further decline of the incontinence or of any other challenges surrounding the incontinence. I mentioned improving toilet function. And when I think about that, oftentimes I'll hear, well, they can't ambulate to the toilet, so we're using products. And I think that sometimes we need to go back to the basics and remember that when someone can't ambulate to the bathroom, it's not a reason not to try and toilet them. We can use assistive devices like a bedside commode or a fracture pan or a bedpan, and try and help them gain some function that way. I like to think of incontinence management as the 5th quality improvement program, and that we treat it like a quality improvement program, and it's not just a list of our patients that have incontinence. So when I look at other QI programs, I think about wound prevention. So we know that most institutions are going to have some kind of wound care team, a very multidisciplinary team that's very focused on wound prevention. And then unfortunately, if some kind of pressure injury or wound occurs, that they're very diligent on that. They're rounding weekly. They've brought in wound consultants. They're really diligent in making sure that that individual, that wound gets healed. Infection control, we know that the main goal of those programs is to stop the spread of infection or mitigate that within a setting. Again, usually a team involved there, very widespread in the facility or the center, to make sure that everyone understands good infection control practices. Like fall prevention as well. Everyone knows what that program is. They know there are people that are at high risk for falling. Again, that correlation with the incontinent individual and falling. And then nutrition. Most people, if they're in some kind of institutional setting, are going to have some kind of nutritional compromise, and we're diligent about that too. They're having a registered dietitian consultation. They may be on supplements. We're making sure that they're getting nutritious meals. And so I kind of like to think of incontinence then as the 5th one, that we don't simply, as I mentioned, say, here's our incontinent individuals, but putting that incontinent individual at the center, and all of these issues could be happening to that person as well. So really looking at that incontinence person, they become, part of the data that we're looking at in our quality improvement programs. We all know that there's quality measures around incontinence, and that we're really digging into those measures to see how we can try and improve either their level of continence or decrease the level of incidence when it comes to incontinence. I want to talk just a little bit about the impact of skin alteration on a person. So we know that it does, hugely affect their quality of life. Someone that has a skin alteration is receiving treatment, so they might more likely be in their room. They might be bedbound. They may be spending less time up in a chair for extended period of time, which can sometimes lead to isolation. They're, especially if they're cognitively intact, may be aware that they're not out and about and doing their routine activities. And so that sense of isolation can also lead to mental health issues like depression. Pain management, I think Dr. Buddensiek did a great job of showing IAD and pressure injuries and how they can be very painful. And as elementary as it sounds, I think it's a good reminder to our nursing staff to remember if someone is receiving some treatment for IAD or pressure injuries, that we're providing pain management prior to that treatment, some kind of pain analgesic or whatever the physician has ordered, and that we're doing that, timely, so that when they are having the treatment under their skin, which we know is very painful, especially with IAD, that we're helping them as much as we can. Limited mobility, again, goes back to a little bit about the isolation. So someone that, again, is having treatments done, we typically will, especially with IAD, the pictures that we saw, keep them more immobile, right? In bed, turning, keeping them off of that affected area, doing treatments. So with that, we sometimes maybe are promoting a little bit of decline in function because of that immobility. And then once we've done that, we also can kind of counter creating dependence. So this individual's been having all of this care delivered to them during this time. They've been completely dependent when before or prior to the skin alteration, maybe they had a little more independence. And then again, I think I mentioned a cascade of health issues. So, we do know, as Dr. Buddensiek mentioned, that the incontinent individual is at risk for IAD, and that IAD is then a risk factor for pressure injury development, as well as secondary infections, the urinary tract infections, fungal infections, and then additional skin breakdown. When I look at quality improvement, I think about these 5 pillars. I think that incontinence is a very patient-centric condition, very patient-centered focus. And not every incontinent individual is the same, just like every patient that has a wound is not the same. They all might have different treatment protocols in place. So I like to think of incontinence the same way. And so by understanding those individual needs of the patient will lead to a more personalized and effective plan of care. I'll give an example when I think of, and I'll talk about this a little bit later, is that someone that has stress incontinence as opposed to someone that has overflow incontinence has very, very different needs. Their cognition also, someone that's cognitively intact or someone that has dementia, their incontinence is very different, how you're going to treat that as well. So it is more than just, here's my incontinent patients, and this is what products we're using, or this is the treatments. It's really very patient-centric and should be part of, well, when it is the part of the plan of care, it is a focus just like other issues that the patient or resident is having. And then evidence-based practices, having the most up-to-date research and clinical guidelines, products available, are going to lead to better patient outcomes. Letting your staff know what your protocols are, what your treatments are, and communicating with them is really paramount in this area. I touched a little bit on multidisciplinary approach, but really when I was talking more about wound care, and I think the same for incontinence. We need to have a team of professionals involved in the incontinent individual. Urology to maybe, come up with some diagnosis. Is it a neurogenic bladder? Is it is their kidney function declining? What's going on with them physiologically that's causing the incontinence? Are we really digging into that as opposed to just labeling them as incontinent? Clinical, of course, assessment is paramount from the nursing team, and not only assessment, but then based on that assessment, how are we communicating that down to the nurses' aides, the PSWs, whoever it is that's delivering that care. Occupational therapy and physical therapy, but I guess I think more about occupational therapy with the incontinent individual and helping them with their activities of daily living and helping them get to the toilet. If they're cognitively intact and are using a bladder control pad or something like that, are they able to help them with how they change that pad and trying to keep them from going to another higher level of product. Education and training. Again, I think we always think about our staff and training our staff of what's going on, but we really need to remember too that when our patients are cognitively intact, explaining to them everything that we're doing, explaining to them about their incontinence and what's going on with them and how we're dealing with it and how we are managing it. And that can ultimately lead to patients receiving, a higher quality of care. And if they're informed, then, perhaps they'll adhere more to the treatment recommendations that the staff is trying to convey to them. And then monitoring and evaluation, of course, the end cycle and that whole quality improvement wheel, if you will, tracking the patient's progress, looking to see if the patient or the resident is having further decline in their incontinence, and really looking at that data-driven, again, from a quality measures standpoint, identifying these areas for improvement and bringing in them to that whole quality improvement discussion. I'm going to talk just a little bit about prevention and management, but Dr. Buddensiek mentioned managing microclimate. And when I think about this, I think about when I see incontinent residents in bed and you go in to maybe change them or you go in to do a treatment and you take off the blanket, you take off the sheet, and then they might have an incontinent product on, and underneath that, they might have some kind of disposable Chuck's pad or blue pad, or they might have some kind of cloth pad underneath that. And then they have their sheet, and then they have some kind of most likely preventative mattress. And when you think of all those items stacked up, that can lead to a lot of heat buildup. And so when we talk about managing microclimate, we're talking about managing the skin moisture, the skin temperature, and the skin shear or friction. So we have the limited mobility of a person. They might have a previous skin condition. Then they have all those other things going on with moisture, temperature, shear, and friction, and it leads to this like perfect storm, I think of, for them to develop some kind of skin condition like incontinence-associated dermatitis. So keeping that in mind, when you think of what is closest to the body in the trunk, and again, we'll talk about absorbent products and breathability, but it is something that really should be looked at. And when I think of the shear or friction and how we are moving our patients in bed, kind of getting back to basic nursing practice of not using really thick cloth pads, but maybe using more of a thin draw sheet or a true lift pad for the patient or resident to really try and decrease that moisture, temperature, and friction, and leading to a more favorable microclimate. And products are designed that way now too, to thinking, about microclimate. I like this slide because it's simple. And I think that, when you think of a clinical team and you think of nurses and you think of caregivers and their day-to-day activities and what they're doing, they're super busy. They have so much going on, and they're taking care of our most vulnerable population when you think of the post-acute arena. And having something simple for them to review and to provide education, I think, is paramount. So assessment is, very basic in this area as far as skin inspection. I know when we think of assessment, we think of the licensed nurse, which is true, looking and inspecting that skin. But I think it's so important that the nurses are educating the frontline caregivers about skin inspection, and that it's not happening daily, but it's happening continuously with each change of an incontinence product or every time someone's being dressed or someone's being toileted, that it's just a common practice of, I'm going to offer a drink of water, and at the time that I'm giving care, I'm also going to inspect their skin and reporting at least the slightest change possible. I have a lot of interactions with CNAs and PSWs, and that's one thing that they have said to me in the past is that if we only knew, we'd know what to say. So just kind of keeping that in mind, making sure that we're always educating the staff that's really giving that direct care. And then, of course, we have in here the assessment components. And then moving on to the C of ACT is cleanse. Cleansing the skin with a really nice pH balanced skin cleanser using surfactants. Still see soap and water being used, and Dr. Buddensiek explained that nicely about what can happen to the, the mantle of the skin, especially with soaps that can be very drying. And if you think of soap and then a washcloth, and a washcloth has a nubby appearance, and then even go back further and think of that IAD skin, how painful that could be. And it's just good practice to use either a pre-moistened wipe or maybe a dry wipe with a skin cleanser, and then trying to correct the cause of IAD if possible. But I think when I look at like ministry guidelines, and in the states, we look at federal guidelines, and we look at deficiencies or tags that might be given out by the health department or state surveyors. A lot of times we see it around this area, around how cleansing is done, how pericare is performed, and that some of these steps are missed or the appropriate products aren't available for the staff to use. So I can't overemphasize enough the cleansing part. And I think it's a great idea with your staff to, if you're doing skills fairs, it's a great idea to, bring that into play, or maybe have your infection control designee do spot checks with your staff while they're performing cleansing of the incontinent resident to make sure that they're doing it appropriately if they have any questions. So that would probably be my pullout from this slide, would be the cleanse. I think Dr. Buddensiek did a great job talking about the treatment modalities. We have them listed here as well. When you think about skin moisture, we want to make sure that we're using super absorbents that actually pull moisture away from the skin. Again, I'll get into that in just a little bit. And then preventing traumatic injury. So being super mindful of damaging the skin with certain tapes, and then using fluid lock dressings when appropriate. And then just some additional for managing IAD specifically. Of course, indwelling catheters, last resort and temporary. So when you think back of those pictures that we saw with some very scalding-like appearance of skin, sometimes the catheter is medically justified for short-term use, because it's just going to be continually irritated by the urine or feces. And then external catheters, which are nice now to have for a female version as well as male, can be a nice temporary solution while the skin is being treated and healed. Fecal management systems as well, if there's liquid stool in the form of a pouch, of course, those I think too can also have their own set of challenges if not applied correctly. And then of course, quick attention to bowel incontinence. I have that in here, even though it seems so elementary. I think it's a great educational reinforcer to staff that's providing the care, that how caustic stool can be to the skin. And if you think back to the slide earlier that shows that arc of IAD with urine and feces formed, urine and feces liquid, how that incident increases that risk with those three factors. And sometimes, in compromised residents, they might have more of a liquid stool. So again, really threw that in here as an education component to make sure we're reinforcing that with the staff. And then a structured skin management program. Things should heal within 1 to 2 days, resolve in 1 to 2 weeks. That's assuming that not a lot of other comorbidities going on. And disposable products we're going to get into. So a few things with choosing absorbent products. First and foremost, the type of product. Choose for the level of leakage. Someone that is having stress incontinence probably doesn't need to be in a brief. They could maybe have some kind of bladder control pad. Level of mobility needs to be considered, product fit and size, and daytime versus nighttime. Oftentimes people might need a lesser product during the day and a more boisterous product at night, if you will, for lack of a better term, depending on their preferences. I know this is a busy slide, but I wanted to put it in just to show you that there are quality performance standards of disposable adult absorbent products. And this is the National Association for Continence. And these are minimum standards. So there's key areas that are looked at when products are tested from a standard testing method. And that is re-wet weight, which is the measure of a product's ability to withstand multiple incontinent episodes. So we know that when someone has a urine episode or a fecal episode in a product, we want that changed right away, but we also know the real world is that sometimes that might not happen. So that's a measure of the re-wet. And then rate of acquisition is the measure of the speed at which it's wicked away or drawn into the product. Retention, the measure of the product's capacity to hold the fluid. And then breathability, I mentioned that with microclimate. What is the breathability in the chassis of the product to allow an air exchange onto the skin? And then elasticity, making sure that gentle elastics are used. I think we've all probably seen skin damage from elastics in products that aren't applied appropriately. And then the types of products, the categories, light, medium, heavy. Again, someone with stress incontinence might be better off with a bladder control pad. These can be gender-specific products. Females their whole life, since they were, young girls, have been using menstrual pads, so they're used to using a pad. Men have not done that. So that's something new to the male population. So having something that's geared towards the male that might be a little more discreet is super appropriate. And then medium urinary would be more of protective underwear or adult pull-ups. I like the term adult pull-ups because I think it's more dignified as opposed to, thinking of children that wear pull-ups. Adult protective underwear is really more appropriate. So also these are gender specific and really more appropriate for urinary, not for fecal incontinence. And this is a great product with someone that's toileting. And then heavy and urinary bowel incontinence is a full adult brief. And they can either be a 4-tab or a 2-tab brief. And this is just another way of looking at trying to select a product for an individual, looking if they're mobile or non-mobile, should certainly be taken into consideration. Again, I look at incontinence products as using the least amount of product possible to start off with instead of the most restrictive, kind of like the wound selection. I wanted to talk real quickly about doubling. So I often see residents, patient wearing more than one product. They might wear protective underwear and then someone puts a bladder control pad inside of it. And then they just take the bladder control pad out and put a new one in and don't provide peri-care. So again, I think we all know what can happen with that is potential for infection. So when you think about doubling products, the product closest to the body is the one that's going to receive the insult. And if you have another product underneath here, that's never going to get down to it. It's going to be absorbed. So as you stacking in double products, you're also creating heat, moisture, friction, all of the things we talked about with microclimate. So again, something we still see. And I think that people that are double padding products, they do it with all good intention. They think they're going to get more coverage when in fact it can be detrimental to the skin. And then the benefits of using products properly, of course, is, containing urine and bowel, enhancing quality of life, providing a secure and comfortable fit can actually help maintain a normal lifestyle and daily activities. Gone are the products that were big and bulky and plastic. They fit more like undergarments and regular underwear and can really provide a dignified fit and let someone be up and about and out in the community. If chosen and applied properly, they can mitigate the incidence of skin damage, maintaining a healthy microclimate, and actually reducing supplies needed by getting the correct product the first time as opposed to using multiple. And then ultimately, which we know is important, especially in institutional settings, is having cost savings by using the products properly. And then education to caregivers, I think is, again, I know I mentioned it before, but creation of clearly defined protocols that are evidence-based and cost-effective, making sure that everyone that's involved in the incontinent patient care is aware of them, that they know the plan of care, they know how the patient's being treated, they know the risks associated, they know where their supplies are, having a nice formulary of products. And that doesn't mean that they have to have 100 products. It means they need to have a good handful of products to meet those patient-centered needs. And then ultimately continued research to enhance the understanding of IAD and its prevention and treatment. So to summarize, and I'm kind of going a little bit quick here because I know we're running out of time, is that incontinence-associated dermatitis definitely has a significant impact on the quality of life. And I think we've shown that throughout the presentations. Patient at risk for other types of skin alteration. The treatment can be lengthy, it can be full of complications, it can be costly. The physician and clinician have key roles in prevention, treatment, and management, as well as the other members of the multidisciplinary team. And effective incontinence management really is essential in all healthcare settings to reduce the occurrence of IAD and other skin alterations. Thank you, everyone. I'm going to just go ahead and go to the very last slide with our contact information and turn it back to you, Troy.
Keep this slide up for a little while just so people have a chance to take a look if they'd like to get in contact. But I want to thank both of you for such a fantastic presentation here. And I know we've got some great comments coming into our chat here. And I think really harping on that importance of education across whatever facility they might be, from our physicians all the way to our frontline staff, to our unlicensed care staff, our PSWs, et cetera. So thank you both. And we do have a couple of questions if you've got a couple minutes with us. One of them, first, we had a question from Shelley who was asking, how can we be certain that there isn't an infection before using the liquid acrylate? And this goes back to one of your kind of earlier slides there, Dr. Buddensiek.
No, thanks, Shelley. I mean, we can never be entirely certain, right? Unfortunately, because we're human. But I think, rule of close inspection of the area, looking for those almost pathognomonic types of signs, which would include those satellite lesions, feeling for if there's greater warmth than just the normal body temperature, which may be more of a bacterial cellulitic type of infection. I think that's where we really just try our best. It's not the greatest thing to have to say, but close inspection and really trusting your gut as far as, is there any pathognomonic types of signs of fungal or bacterial infection.
I think it's really important. And we had another question a bit on the topical treatment too here. When should we be applying, or when is it appropriate maybe to apply an anti-inflammatory agent to help with treating IAD?
I'm not aware of any particular international algorithm where it says this is exactly when you should use, a steroid. I mean, there's one of two ways that I approach it clinically, and that's where we take in our clinical experience as well as patient preference. I mean, if you're seeing this individual for the first time, and this is just very severe, and they've not been using incontinence prevention strategies, well, then I'd say just go all in with that initially, give it 3 to 5 days, and it sometimes miraculously, the skin is such a great dynamic organ that it can really improve quickly. Someone else might be in so much pain other than using systemic types of medications like a acetaminophen, to help with that, at least, even for our frail elders. You may decide that in sort of a shared decision making, if there is no infection, that we go ahead and add the steroid right up front as well. Otherwise, I will wait typically and use the steroid sort of as a plan B or a plan 1B type of strategy rather than using it right away. But yeah, I think there is some clinical judgment and also that shared decision making with the patient and their family.
That's very helpful. I'm going to ask a more general question here. especially because I know that you've worked quite often with helping consult for long-term care, one of the largest long-term care chains in the States there. And I was wondering if you had any key times where, or examples where it's been difficult to have a full staff implement patient education for IAD, or even just having the full team really integrate prevention and management for IAD. What are some of the major problems or recurring problems you might see that you've helped advise on in the past?
Well, we know that probably no matter where you live in practice is, we would love to have a retention rate of our own staff or associates of 100%, right? And that doesn't happen. I think no matter what, and I think Michelle had mentioned it, was, I mean, you got to make this fun. I saw comments there that you can do it in, game format. You can do it in skills fairs. I mean, a growth mindset should be contagious. And so if nothing else, it's building that culture from where that foundation of growth and development of your nurses, of even your nurse aides, and certainly the leadership need to build that fund of knowledge and be collegial, be respectful, and really trying to look at this as is really not a punitive, type of thing, but rather a growth and educational endeavor together. Easier said than done when you have different people coming in and leaving and agency staff. I mean, it's very dependent on the facility, but that, I think we know, culture is so important, which then will lead to more retention of associates or staff, more growth mindset of the right people. But again, easier said than done. I think, though, the skills fairs can be very critically helpful. And, looking at across an entire year, perhaps, of what types of trainings you have that are sort of systematized. So you're not having to reinvent the wheel. And maybe Michelle can even talk about that briefly. But I look at it more in the have fun, growth mindset culture, as well as let's systematize those so we have high reliability of certain content throughout an entire nurses or aides journey through a year and through the organization of growth.
Yeah, I think I would just quickly add to that. And I agree, having the training on the calendar in a regular cadence, that it just doesn't occur when something happens, but it's something that goes on quarterly and it's repeated education.
Important that you mentioned that. And this is another reason why we thank you so much for bringing this kind of education to us here too. Because, for example, someone was mentioned a little bit earlier that while they do their own education, it's things like even like these webinars that do help quite a bit for refreshing some of that information too. And that's why we're such a big proponent here of having this education across multiple different, the whole interprofessional team, from our NSWOCCs and our specialized RNs, our SWANs, of course, working collaboratively with our NSWOCCs, and our PSWs and caregivers as well, where we're also trying to focus on this IAD topic too in our courses. So on that note, I really want to thank both of you again for taking the time and for the support of First Quality, of course, for being able to deliver this today. It looks like we had such a great crowd with us today during the workday, especially, but I can tell people from across Canada have all been able to join. So no matter their time zone, it was great that you were all able to join with us today. And we hope this is first of many educational opportunities in the future. So I want to thank both Michelle and Dr. Buddensiek here for coming on with us today.
Thank you.
And just to finalize, for all those who are on the call, just a reminder that you will be receiving the certificate. Just give us 2 business days here. We're going to work really hard in the background, but you'll be able to get that very shortly along with the recording too. So with that, we'll say have a good rest of the workday, or from wherever you're tuning in. We hope to see you again in 2025 for another edition of our NSWOCC Walk Institute webinar series. Bye, everyone.